This is the first question. After providing teaching to a client, prescribe fluoxetine, which client statement indicate effective teaching? So, what is the deal? Why did I say this question? Patient was prescribed fluoxetine and the nurse has provided teaching. Which of these indicate what? Effective teaching. The NCLEX will give you things that they know you're going to pick. You all know some medications you have to remain at upright for 30 minutes. We all know about grapefruit juice, right? Those two things, it does not apply to everything. Not every medication you got to remain upright. Not every medication you got to avoid grapefruit juice. These are trap answers. They know you know. They put it there. It has nothing to do with fluoxetine, right? This is SSRI. And another side effect is photosensitivity. If you know it, you don't even have to worry about it. Large number of people pick this or that because that's what everybody know that some medication you got to remain upright. Some medication you got to avoid grapefruit juice. It does not mean it's right. It has nothing to do with the question. So don't fall for these kind of answers. At the same time, SSRI takes a couple of weeks to take effect. Therefore, just by elimination, you know that this is your right answer. Question 2. Which finding in the client with acute post-streptococcal glomerulonephritis is concerning? You cannot answer the question without knowing what is this problem. Acute post-streptococcal glomerulonephritis. Even if you don't know, there's an acute, it happens sadly. It's post-strep infection. At the same time, pay attention to this glomerulonephritis. What is happening to the kidney? And that will help you find the answer over here. It sounds really difficult. It sounds confusing, but don't worry. Go for the pathway. It happens acutely when you have strep. And what has happened? This is the key. This is what you need to focus on. Not all this. This is the problem. What is happening to the kidney? And I pick an answer choice that is consistent with this problem. Right. So what is your answer? Smoky, dark color, urine. Right. So this is the key, right? Anybody who have post-streptococcal glomerulonephritis, inflammation of the kidney, right? Due to is a autoimmune related to the strep infection. What do you think? You're going to what? Kidney renal failure. Your urine is not going to be yellow. It's not going to be clear urine. It's going to be smoky and dark and colored. That means it's dark, consistent with renal failure. All this is track, right? It's consistent with that. It's not concerning, right? And the kidney is in trouble. Well, you're going to retain fluid. That's why you get edema. The kidney is in trouble. Your creatinine is going to go up. Yeah, if you're not getting rid of fluid and you're in renal failure, bilateral Coccus is more dangerous than all of this. An expected finding, bad complication from retention. So that's your answer. And that is what's hard to answer questions, no matter what kind of test you're taking. It's all based on you trying to break down the question first before you answer it. Same thing, client with end-stage liver disease and chronic hepatitis B is admitted for hepatic encephalopathy. Which finding the nurse should respect? Don't worry about it. Buzzword, read it from the back. Which finding the nurse should respect what? Patient has this chronic hepatitis B and end-stage liver disease. Why is it the patient in the hospital? Not because of that. Not because of that. It's not because they have end-stage liver disease. It's not because they have chronic hepatitis B. It's because they have what? Hepatic encephalopathy. So every answer choice is based on this. Okay, break down the question into the little pieces that you can answer it and connect them. What do you expect? I can rewrite this question again. What do I expect in hepatic encephalopathy? That is all. All this is to trap you, to distract you. But the question is, what do I expect in hepatic encephalopathy? That's all. Right? When you have end-stage liver disease, your liver is going to be small. It's not going to get bigger. Right? Patient has hepatic encephalopathy, everything is going to go down. If you don't know what it means, I've given you a clue. Anybody with hepatic encephalopathy, they go into coma. Everything is down going. They're not going to be agitated. They'll be lethargic. Their reflexes will go down. When they stretch out their hand, it flaps, right? Asterixis, right? So that's your right answer. Right? Like you say, if you figure out this is what the key question is, the rest of the answers will pop out like a candy. So that's the key to this kind of question. Next question. What is the next priority intervention for a client with stage 3 sacral pressure ulcer? Same thing. You see, I'm trying to eat the same term, right? When you break down this question, keyword is stage 3 sacral DQ. What do you want to do as a nurse? Is a priority intervention. You don't want progression of this stage 3. Therefore, which answer choice indicates that you're not progressing, you're not causing progression? So your intervention was to prevent progression of the disease. So which one would you pick? Clean the wound thoroughly with hydrogen peroxide, massage reddening area to prevent skin breakdown, provide overlying or foam mattress and kinetic bed, and keep cleansing solution very cold, right? I give you the key thing you need to focus on: sacral DQ stage 3 ulcer, right? Well, first of all, hydrogen peroxide is not used to clean wound. We all do that. It destroys, kills the tissue, and it's not indicated. If you massage the reddening area, it's going to progress to another stage of pressure ulcer. You provide them bed and you turn them every 2 hours. You offload pressure areas. This is exactly what this is saying. When you're taking a board exam, you see answers that is not what you expected, but you know it's the same thing. This is like I can put offloading pressure. It's the same thing. If I provide a foamy mattress and I'll give you a bed that moves, it's the same thing. Don't expect certain answers. The answer is there. Whatever you know is there. You can't, if you go and take the NCLEX, they're not going to give you answers that you've never seen before. They are the same answers by using language to trick you, to change it. I can say the same thing. Overlying bed is a foamy mattress, is a kinetic. Idea is to offload everything. Solution should not be cold. I mean, it should be warm body temperature to help with wound healing. In next care for a client with ulcerative colitis, prescribed sulfasalazine, which teaching at discharge is appropriate. Antibiotic, okay, agent for inflammation, right? This is used in ulcerative colitis. But pay attention to the question: which teaching is at discharge is appropriate? So you have a patient with the UC in taking sulfasalazine. You have to provide certain answers to them to take care of them. Every answer choice you answer, whether it's a UC or sulfasalazine. Will you give somebody with a high residue diet and calorie diet for somebody with the UC? Do they stay on raw vegetables and fruit and whole grains? Do they drink 2 to 3 liters of water a day? Or do they limit their alcohol and caffeine? 2 buzzwords: ulcerative colitis, sulfasalazine. What do you think? Then you go. Ulcerative colitis is inflammation of the colon from the rectum all the way to the whole colon is basically affected, right? And it's mucosal problem, ulceration, and they bleed. They have a lot of bloody diarrhea. So they're going to be dehydrated. So they should be drinking 2 to 3 liters of water a day. Because they have multiple inflammation, multiple bowel movement, they should avoid high residue diet. It has too much fiber in it. It will give them too much diarrhea. But they need calorie. So this answer is a wrong answer and then correct answer. High calorie, but no high residue diet. What did I do? High residue, I just changed it. Raw vegetables, fruits, and whole grains. It's the same as high residue. All these questions are concepts I take and I just try to trap you, right? You should not limit your alcohol. You should stop it because this is an irritant. And it's going to give you more diarrhea. Caffeinated drink, alcohol, smoking, I call them the cats, right? Caffeine, alcohol, tobacco, smoking, you should avoid all the time. Don't even limit it. Okay, so that's why hydration is the best answer for this patient. And this is evaluating a client in the ED with hyperosmolar hyperglycemic state, with finding the next you expect. You don't have to worry too much about it. They give you, this is the keyword, HHS. What do you expect in this condition? Every time you see something like that, endocrine question, write the opposite. What is the opposite of HHS? HHS is what? Diabetic ketoacidosis. If you know what is diabetic ketoacidosis, write it down and then check the answers and see if you can see things that is consistent with DKA and you pick them out. Whatever is left, it belongs to HHS. That's the way to do bi-directional endocrine question. So, is this consistent with HHS or DKA? Fruity order or DKA? HHS. Urine ketones, is it this or that? Or your serum glucose of 620? Right. HHS, there is no acidosis. Your pH cannot be 7.2. If you have no acidosis, you can't have ketones, right? If you don't have ketones, you're not going to smell fruity. You see what I did? This is how you apply concept. I know this is HHS. There's not going to be acidosis. pH of 7.2 is acidosis. If you have pH of 7.2, it's coming from the ketones. The ketones will let you smell like fruity. Therefore, if this is not the HHS, then this has to be glucose is 620 and above. And next is planning care for a client receiving brachytherapy. Which action should be included? Okay, one word in the question, a buzzword is brachytherapy. Know what it is, and they use it to answer the question. If you know what it is, see whatever you're seeing is know what you would do if you're taking care of a patient with brachytherapy. Do you let a visitor stay for 45 minutes? Do you allow the client to walk to the bathroom? Do you give them laxatives to prevent constipation? Or do you restrict them to bed? So what should you include? What would you include? Brachytherapy is internal radiation. So this is internal radiation. We use it for cervical cancer. So this is the woman. They have internal radiation through the cervix and then providing radiation directly. They cannot get out of bed. If they get out of bed, this will dislodge, it become a problem. That's why they have to be bed rest. If you're going to get out and then the thing is going to fall, why do I have to walk in the bathroom? This is another way of answering questions. You see, I should go to the bathroom, but this says strict bed rest. You know, one of those has to be the answer. Therefore, you have 50-50 chance of getting it. That is the best way. Visitors can stay up to 30 minutes. Then look at what I'm going to show you. I know I'm going to keep you to bed, and you should not get out of the bath to the bathroom. Therefore, why would you want to give them laxative so that they don't have constipation? You want them to be constipated, rather. Don't go to the bathroom. Don't poop, okay? And stay there for 5 days is good, right? So if you give them laxative, they gotta poop. They will get up, right? Unless you put a catheter through, it's a problem. So this is how you can say, this does not make sense. If I'm going to keep you to bed, you can't walk, I cannot make you poop. So these are key way to put concept together. You can't memorize your way through medicine. Sometimes you have to understand and apply it. And this is review assessment notes on a client with Addison disease by LPN, which finding the next question. I changed the question, right? LPN did exams on a patient with Addison, and this is what he wrote, he or she wrote. View the nurse, review the notes. Which one you think the LPN is wrong? You should not expect it in a patient with Addison disease. What do you think? Do you expect postural hypotension, weakness, hypopigmentation, or muscle wasting? You have to question this. So which one should you question? That means something that you don't see it in Addison. If you see it in Addison, then you got to stop it. You don't have to pick it, right? So Addison, what is the problem? They don't have aldo, they don't have cortisol, and then they don't have sex hormones, right? In the process of not having sex hormone, they have all hormones that give them a lot of melanin. These melanin make their skin pigmented. That's key. Because you don't have aldo, you're going to have postural hypertension. You don't have steroid, you're going to get weak. You don't have steroid, your muscle is going to waste away. You have too much melanin, your skin is going to be pigmented. It's not going to be hypo, it's going to be hyperpigmented. I said this question to trap people. You see a pigmentation, you do not look what is in front of it. Everybody know how these same people are pigmented, but I put hypo. If you don't read it carefully, you think it's the right answer. That's not the right answer. Hypopigmentation is not consistent. You should question in Addison patient. And this is evaluating a client in the ED with suspected diabetic ketoacidosis. Which finding the next you expect is the same question I give you. I just flip it. So which of this should you expect in a DKA? That's all. I explain it to you. If you know DKA well, then write it down. But if you don't, you know HHS, you say this is what I expect in HHS. Any answer choice that I don't see it in HHS, it has to be a DKA. You expect this in DKA? You expect this in DKA? You expect this in DKA? Or do you expect this in DKA? Shallow, slow breath. Leg edema, refusing to drink, abdominal pain. Why abdominal pain is the right answer? Look at it carefully. DKA, you have ketones, you develop acidosis, you smell fruity, and in order to get rid of the acidosis, you have deep, okay, deep, slow, Cushman breathing. It's not shallow, it's deep breathing. That's how you get rid of your CO2. So this is wrong. They are dehydrated. Their leg is not going to have edema. They will be thirsty. They're not going to refuse to drink. They have abdominal pain because of dehydration. You should be able to explain away every answer trace based on the concept. What is the next priority action for this EKG? I mean, if you can't see, I will help you. But if you look at the EKG, there's something going on here. These guys, these are abnormal. What do you think they are? These are abnormal. So these are the ones you should worry about. If you know it, then you know what to do with that. But if you don't know it, that's taking strategy. You can tell that answer choices are giving you a clue. I tried to help you. The answer choice is giving you a clue. What kind of clue is it giving you? Look at the clue it's giving you. What is each of them doing? You can see is related to one problem. Calcium gluconate, furosemide, D5 with insulin and hemodialysis. This is dealing with what? Potassium. As you can see, peak T wave on the EKG. Because there's the EKG changes, we got to protect the heart first. All this can be used to treat hyperkalemia. But whenever there's the EKG changes, you got to protect the heart. And so this is, you can see the peak waves. And so calcium gluconate stabilize the heart. And let's care for a client with a heart rate of what? 130, blood pressure 90/40, SAT 94 on 6 liters. Patient is diaphoretic, and this is his EKG. What action is a priority? You have everything you need to answer the patient question. Heart rate 160, 130, blood pressure 90/60, saturation of 94 on 6 liters. I'm sweaty and I have this EKG. What do you want to do? Immediate defibrillation, prepare for intubation, initiate CPR or synchronized cardioversion. These kind of critical care questions, they're straightforward. If you make a diagnosis, what is all this is telling you? Sometimes you don't have to disturb your brain too much. What is all this telling you? So use that. Sacral is what is all this? It's telling me one thing. One thing plus EKG is what? One thing plus the EKG. All this is telling me patient is not stable. Your SAT is 94 on 6 liters. You're tachycardic and hypotensive. And if you're not stable, what is making you unstable? This, what is that? You don't see atrial rhythm. This is all ventricular. It's uniform. This is called VTAC. Therefore, if it's a VTAC unstable, you got to synchronize cardioversion. Patient has a pulse. That's why they have blood pressure. Therefore, you cannot defibrillate. There's no need to intubate the patient. Patient needs cardiac function. And so you got to synchronize them. No need for CPR. Right. So this is a hard question, but it's a critical thinking question. If you just put all these things and put it in one, patient unstable VTAG, get cardioversion. Rewrite the question. And let's care for a client with 50% total body surface area burn to the body in the ED. Which prescription the nurse should expect? This is an integrant question, musculoskeletal a little bit, but you have to know when somebody got burned and come to the emergency room, what medication would you suspect? Resuscitate with normal saline, resuscitate with lactate ringer, keep the patient some liquid, clear liquid diet, and start antibiotic. Don't get trapped. Look at it carefully. Make sure you understand it. But this is one concept you have to know. I come in, I have this. What were you going to do? 40% total body surface area. What do you do for this kind of situation? You give them something to drink, IV fluid, normal saline, and give them lactate ringer. It's just a concept. What do you do for a 40% body surface area? The priority function is resuscitation. They are in shock. They're going to be in shock. Give them fluid. The best fluid is lactate ringer. Why normal saline? Because if you calculate, if I give you the weight of this person, At minimum, they will be needing like 6 liters in the very short term. They're going to get a bunch of fluid. If you give them normal saline, too much normal saline will make you acidotic. So excessive normal saline make you acidotic. So metabolic acidosis. That's why we don't resuscitate too much with normal saline in a burn patient. We choose lactate ringer, which has some bicarb and take care of the acidosis. The client is now post total thyroidectomy, which finding the nurse should report to the healthcare provider. Buzzword, total thyroidectomy, and remove your thyroid. Which of these you got to talk to the doctor about me? I have 6 out of 10. Numbness around my mouth. Some dysphagia when I swallow, and the dressing is thin. What is your priority? You got to be sharp. Which one is trapping you? Be sharp. Which answer indicates you are being sharp? Choose an answer that indicates is it yellow or is it green? Is it blue? Is that? You can tell. 6 out of 10 should concern you. Dysphagia should concern you. Blood stain and the periorbital numbness. Which one? The key word is, what do you expect is going to be bad every time somebody has thyroidectomy? It's hyperkalemia. Which of this is consistent with hyperkalemia? Periorbital numbness, right? And so that's the one you got to, it's a sign. It's a mild dysphagia. If I put dysphagia, always look at what is following. When you swallow, where they intubate you. So you may have some sore throat a little bit that is expected when they intubate you. So watch what they give you, they qualify. I qualify it for you. So don't let it trap you. Dysphagia is not airway at this point. The client is unresponsive. 1, not breathing. 2, has no pulse. 3, after calling for help, what is the next best action? These are little questions you see on your NCLEX. What is this test question is testing? Whether you know your BLS and ACLS, which you need to know. So if I'm unresponsive, that means you made assessment and I'm not breathing and you check I'm not pulse, that they are not going to tell you make an assessment. Sometimes they will tell you, but when they say the patient is unresponsive and they give you a pulse, and that means you made an assessment. After that, what would you do? Check the pulse again, do chest compression, give them 2 rescue breaths, prepare to defibrillate the patient. What do you want to do? Unresponsive, no pulse, no breathing. What do you want to do? Start pushing on their chest as soon as possible. Chest compression is the right answer. There's no need to wait. You already done everything. You don't need to defibrillate until you find the rhythm that you need to defibrillate. The client post-gastric bypass, that's the buzzword. Post-gastric bypass, report feeling weak, is weak, dizzy, diaphoretic, and cold skin. What action the nurse should take? What do you think? I have gastric bypass, now I'm feeling weak, dizzy. You just post-gastric bypass, diaphoretic, and cold skin. You check their blood pressure, you check your calcium level, you check the incision for bleeding, you check for glucose. Keyword is gastric bypass. What do you think your board is going to give you whenever they mention gastric bypass? There's only one thing, and that is damping syndrome. Every time you take the NCLEX and you hear the word gastric bypass, either they're going to ask you that gastric Down syndrome or some vitamins you need to give them or some electrolyte you should replace. Right. So what should you worry about? Right? Is weak, feeling dizzy, diaphoretic, and skin is cold. Damping syndrome is related to glucose, hypoglycemia. If we check their sugar and make sure they are not having damping syndrome, and that's why they behaving like that. And next care for a client with new diagnosis of anorexia nervosa, which lab finding the next you expect? Another content, what do you expect in a patient with anorexia? Okay, I always say this. I give you this or just PPC, right? But don't worry, these two, you have to know them. Related to potassium, related to phosphorus, and then related to calcium. Those are the common, sometimes magnesium, right? These are electrolytes that you should expect in patient with anorexia nervosa that is going to be abnormal. Which direction do they go, right? Which direction do they go? Most of the time, because of all the vomiting and all the malnutrition, okay, the potassium is not going to be normal. The potassium is going to be low, okay? Their phosphorus is low. It's not hyperphosphatemia. Their calcium is low, right? Their kidney function goes down. In the process, you become uremic. Your BUN goes up and your uric acid goes up. So these are the way you can, anything that is secreted by the kidney will go up. So calcium is going to go down because and they basically renal function and more nutrition. So they have hypokalemia, hypophosphatemia, hypocalcemia, hypomagnesemia. When they come in mostly potassium is low. When you start feeding them, check for phosphorus. That's what is going to kill them, refeeding syndrome. So if you don't know the answer, this is a hard one. But if you don't know, you know that the potassium is going to be low, phosphorus is going to be low, calcium is going to be low. Then you got to choose other answers. So don't never shy away from answer choice you don't know after eliminated the wrong ones. And let's care for a client receiving mechanical ventilation. The next you expect the high pressure alarm is due to what? This is classic one. You know patient is intubated, right? And it's connected to machine, right? If the system is intact, there won't be any pressure. If there's a leak of pressure, the pressure goes down. If there is a blockage of pressure goes up. That is every question they ask you about high pressure alarm. Now, look at the answer choice and say, who is going to give me a high pressure? Is it the calf leak? Is it I disconnect the ET tube? Is it I extubate the patient? Is it I'm biting the tube? If you break it down into pieces, you can see that, oh, this is easy. These kind of questions are not that difficult. Is it a leak or blockage? High pressure is a blockage. There is a calf leak. You disconnect the tube, there's a leak. If you extubate the patient, there's a leak. If you bite, there's obstruction. Therefore, that's the only one that will give you high pressure alarm. And let's go for a client with T4 fracture. Which finding is concerning? This is another good question. Look, trust me, if you're taking your ankles and they give you somebody injury above T6, there's one thing they asking you. They have no questions. If they give you somebody with a fracture above T6, you should worry about one thing. This, okay? So that's the only thing you should worry about. You should worry about this AD, right? Therefore, because there's a fracture about T6, which one of this should concern you about AD? That is all. The question is like straightforward, but you got to make it more straightforward to you and handle it. Right? Is it because I have last bar movement 6 hours ago? Is it something I should worry about? Right? Autonomic dysreflexia, because you have fracture above T4, right? You should make sure there's no constrictive clothing. They don't have constipation, right? They don't have urinary retention. These are all things that will trigger them. This blood pressure is normal, right? He's not going to have no movement of his lower extremities. This should not be something you pick. You should not pick yellow because he has T4 fracture. It looked horrible, but he said, oh, he's not moving his leg. Well, he has T4 fracture. What do you think? Do you think he's going to move his leg? No. His blood pressure is normal. Well, I don't think he should be pooping every 6 hours. So if his last bowel movement in 6 hours is fine. He has not have urine for 8 hours. I'm worried about that rather than no pooping for 6 hours. Therefore, this is more likely. His bladder is distended. You start going crazy. You got to pick it. The client with new stroke shows sudden onset to personal changes in behavior. Which area of the brain is affected? If you know the brain structure and which area of the brain, right? So you have the frontal lobe, you have the occipital lobe here, you have the temporal lobe right here, and parietal lobe. So right, each of them do their own thing. So if you divide the brain, this is the frontal, this is the occipital, this is the temporal lobe. There is two temporal lobe here and a parietal lobe is in the middle. All of them doing something. What do you think? What does the function of changing personality and behavior? I'll give you a clue. Occipital is the back of your head, so mostly vision, right? And temporal is on the side. Your ear is here. You're hearing, right? And balancing, right? Therefore, which one control your personality? It's always the frontal lobe. They will have this inhibition. They will say things they're not supposed to say in public. So that's that one. And parietal lobe is the integration of everything. So know that function and how each plays a role. And then provide teaching to a client with coronary disease. Which client statement indicate correct understanding of the teaching? Well, I will engage in moderate exercise 3 times a week. I will call EMS if I have heartburn and that is not relieved with antacid. I will stay on 3 grams of sodium. I will avoid unsaturated fat in my diet. I read this one. I think I have 2 answers there. And I mean, I've made a mistake just by reading it. I can see 2 answers that may be possible. So moderate exercise is just walking for like 30 minutes, 3 times a week. This is acceptable. 3 grams of sodium is too high, right? You got to stay on 2 grams of sodium. Unsaturated fatty acids, this is a trap. Unsaturated fatty acid is the good one. If you don't know today, this is a adaptant class. Unsaturated fatty acid will increase your HDL and then lower your LDL. Saturated fatty acids, saturated fats are the bad ones. So this is what you're supposed to, unsaturated fatty acid like almonds, right? Raisins. So these are like dry fruits. You see them most of the time in them. These are why we say eat vegetables and other stuff. Yeah, so this is good for heart disease patient. If you have a heartburn and it's not relieved by antacid, this is also bad. You may be having coronary disease or MI, so you should call your doctor. Most of the people who have coronary disease, heartburn is heart attack until proven otherwise. And walking also 3 times a day, 3 times a week is also good, moderate exercise. So this one, I think I made a mistake. I should have changed this 4 times. Too much is bad, less is bad, accurate. So this was the answer I was aiming for to trap you I think I forget to delete this one. I think the last question. This is the last question. Which documented findings should a next question in the note for a patient with acute post-streptococcal glomerulonephritis? I explained it to you about this. So acute problem after you have strep infection and you have glomerulonephritis. This is basically acute kidney failure. Rewrite it. Every time you see this acute post-streptococcal glomerulonephritis, it means there's acute renal failure. What do you expect in this patient? The urine of that, urine output 40 and for 2 hours, periorbital edema, and anorexia. You have to question this. Which one you don't see? This question is a little bit trappy. If you don't look at it carefully, this is what I've been saying all this afternoon. It's easy to get trapped if you don't break down the question. It's easy. Acute post-streptococcal glomerulonephritis, it means the individual now has acute kidney injury. The kidney is not functioning anymore. You have tea-colored, dark urine, right? Then the kidney retain fluid. The patient have what? Edema. They have periorbital edema, right? They can have lung crackles, which you have to worry about it. Their blood pressure goes down. The blood pressure goes up. They have hypertension. They have cerebral edema, all of them. And they become anorexic from the BUN. You see what I've shown? Anorexia, periorbital edema. This is bad, but that is what you expected. It doesn't mean 40 cc in 2 hours is because, you are anoric. That means you have renal failure. So go with the concept and don't answer the question because you see something bad. I said question this. If you're going to have renal failure, your BUN is not going to be 20. 20 of BUN is normal. So that is last question to help you think a little bit. But this is what I expect. This is what I expect. This look like you don't pee. Yeah, you're going to go into renal failure. And that's what I expect you to be if you have acute post-streptococcal glomerulonephritis. This is Adaptant Quiz. Thank you for watching. Thank you for playing. Those of you logging. If you want to join our channel membership, you can click Adapted Quiz. We have 2 membership. You can watch some of these videos, or if you need some crash course or demand, you can check my website